So today I am going to talk about the spinal cord and the spinal nerves and how they come off. Now, I did talk about the brain and I gave you a basic introduction of the brain last time. I will talk more about the cranial nerves in the next presentation, but I wanted to give you a view of how the spinal cord and spinal nerves actually work, and I misspelled that. So what we have is we have the brain and spinal cord, and then we have nerves coming off. Now, if you remember, always go back to the bones when you're looking at nerves, I should mention, because if you notice, you have a cervical region, which we're going to refer to those nerves as the cervical nerves. We have a thoracic region, and we're going to call those nerves the thoracic nerves. And we have the lumbar, sacral, as you can see. Now, if you remember correctly, you might remember that you had 7 cervical vertebrae. Well, in the cervical nerves, you have one extra pair. So you have 8 pairs of cervical nerves. Thoracic, you had 12 thoracic vertebrae, and you'd still have the 12 thoracic nerves, 12 pairs, one for each side. Lumbar, you have 5 and 5. Sacral, you have 1 bone, but it's fused in 5. And so you actually end up getting, it's actually 5 fused, so you do end up getting 5 sacral nerves. And you have the coccygeal. Now, just like the vertebrae, they are named by the level they come off, so C1, C2, C3. And you can see where they come. Now, these will actually end up forming a lot of nerve roots that are going to come into nerves. They are going to send messages to target tissues and get messages back. And the way the reason is it's how the nerves actually are formed, and I'll mention more about that. Now, as we keep going, what ends up happening is initially we have a nice tight collection of nerves at an about L2, so lumbar level 2. It breaks apart and forms a bunch of free nerve endings, which we call that area the cauda equina. If you think of cauda means caudal or tail, equina means horse, so it means the horsetail or the ponytail. And so past that you have a loose connection of nerves. Now there is a part up here called the conus medullaris. Again, it's a middle and it's a cone, so cone in the middle. And then you have the cauda equina. And this is actually pretty important for spinal anesthesia and spinal taps. If we were to draw a line straight through the iliac crest, we would actually reach about L4, L5. And the reason we want to be at L4, L5 is because when we go into this nerve area, we don't necessarily hit a tight collection of nerves, so they can move a little bit. You're not going to necessarily penetrate this that much. It's also looser and has more space available inside. So that's why that's why spinal anesthesia is done at the level of L4, L5. Now the first plexus, what happens is you have a bunch of nerves coming off and coming together, and they form what's called a plexus. Now the first plexus that comes off is called the cervical plexus. And the cervical plexus, just like the name suggests, it comes off the cervical area of the neck, and it's made up of nerve roots C1 through 5. Now the main and most important nerve coming off that plexus is made up of the roots of C3, 4, and 5, which is known as the phrenic nerve. Anytime you see phrenic, it usually refers to the diaphragm. So the phrenic nerve will be 2 nerves, one on each side, that goes to the diaphragm and tells you to breathe. The reason those nerves are so important is if they're not working or if they're cut, you won't breathe. Underneath this, you do have the brachial plexus, which brachial, if you remember bones and muscles, you remember a brachial refers to the arm. So the brachial plexus are nerves that are going to the arm. It is made up of roots from C5 to not T12, T2 technically, and it is going to give you a lot of nerves. Now, if you look at the roots here, they're coming off the spinal cord. So you have C5, C6, C7, C8 and T1, and they're going to come together to form these bigger trunks. So you have roots come together to form trunks, here, here, and here. And as you have three trunks here, the one up here is on top, so we call it the superior trunk. The one down here would be the inferior trunk, and the last one here would be your middle trunk. Now the trunks have divisions, and these divisions, three of them, 1, 2, 3, end up branching and going to the back of the plexus, giving you the posterior cord. Now, it's a good idea to look at your arm to see where these things are, because one of them is going to go on the lateral aspect of your arm, and so it's a lateral cord. Remember, you're on anatomical position. The other one is going to branch and give you your medial cord. And so you can see the cords that are coming off. Now, the nerves that come off here, I'll mention in a little bit, but I do want to show you one nerve, and I'm going to highlight it in red so you can see which one I'm talking about. So you'll see a nerve coming here, coming behind, coming here, coming over here, down, and this one is actually going to go to the serratus anterior, and it's called the long thoracic nerve. It's important because sometimes because of trauma, this nerve can be damaged, and it can end up causing the scapula to lift from the ribs, and it leads to what's called wing scapular syndrome, which I have it written down here. The other nerves that are coming off, you can actually see some of what they're called. So you have one that's called the suprascapular scapular nerve, which is going to the superior portion of the scapula. You do have actually thoracic nerves here. You have a lot of different nerves here, but the ones I usually actually like people to know are nerves like the musculocutaneous nerve, which if you listen to the name, musculo for muscle, cutaneous for skin, and this one is going to innervate the big muscles of the arm, such as the biceps and the brachialis, as well as give you innervation of skin, usually in the lateral aspect. The ulnar nerve is another very important nerve. It tends to follow the ulna on the anterior portion, and it pretty much is mainly involved in the forearm. The median nerve is next to the ulna, a little more lateral, going down the middle and going under the transverse carpal ligament. So now you know that there are 10 things that go under the transverse carpal ligament. The 9 flexor digitorum superficialis and profundus, and the flexor pollicis longus. And then the median nerve. Now the median nerve is involved in a lot of the flexion of the forearm. So ulna and median nerve are involved in flexion of the forearm. One's on the lateral side, one's on the medial. It also gives you innervation of skin on those sides. Going to the posterior cord, you see 2 nerves branching off of that. One of them is the axillary nerve, and axillary is the armpit, so it will actually go towards the armpit area. And the other one is called the radial nerve, which is back here. And that one, yeah, here it is. That one is important because it's going to be the main nerve that innervates the extensors of the arm. It is also going to give you most of the sensation on the back of the arm as well. So over here you can see, I found this image, I don't know where, but you can see how the scapula, it comes up. This one's normal, so this would be wing scapular, and that would be a sign of the long thoracic nerve damage. So I did talk about this already, but I'll go through it again. You have the roots, the trunks, chords, and you can see how they're named. And you can see that each one has some innervation from different nerves. Now these are nerves, and nerves, unlike neurons, move in 2 directions. You have some that are going afferent towards the middle body, and some that are going efferent. These are 2 neurons going in different directions in these nerves. Now, I mentioned about the posterior cords have 2 big nerves, but there are 2 big ones to consider. The first one being the axillary, and you can see it back here. You circle it with red. You can see that the axillary nerve is here, going towards the armpit. It actually is found a little bit in front, and that will give you innervation of the deltoid at time, some of the triceps, and a little bit more deeper. The radius, you can actually see how it innervates the triceps, the coneus, and it continues down the posterior aspect of the arm. Again, here you can see the axillary nerve coming to the back here. You can see this suprascapular nerve, infraspinatus nerve, and so you can see how all these nerves go come out and go to the posterior aspect of the arm. Radial nerve, again, you can see it how it comes and how it's going to innervate the triceps, the aconus, the brachioradialis to a degree. So you have the supinator and then most of the extensors of the arm. In short, most of the posterior muscles are innervated by are innervated by the radial nerve. They do give you sensation. Now, if you think about it, why would you think the posterior cord is called the posterior cord? Think about where the radial nerve, and the axillary nerve run. Also, think of where the cord would be in relations to the other two cords. Now, you do have lateral and medial cords, and think about it. Lateral would mean to the side. So if you had an arm here in an anatomical position, your thumb would be here, and your pinky, your other fingers would be here. And so you would have this on the lateral side, this on the medial. So we have the lateral cord up on this side, medial cord down here. And from the medial cord, you have one nerve that's really important, which I don't remember if I mentioned, which I did mention it, which is a musculocutaneous nerve here. There is a place where the medial cord splits and the lateral cord and the medial cord split, forming the median nerve, which goes in the middle. And then you have and so it uses from both cords. And then you have the ulnar nerve, which just comes off of the medial cord. Musculocutaneous nerve. This looks really complicated, but don't worry about it. What you're looking at is a nerve here. And you're noticing it's going to the brachialis and the biceps brachii. And so those are actually the main muscles it innervates. It does have some innervation of this muscle here, which goes from the coracoid process to the humerus, which is the coracobrachialis. It also gives you sensation on the radial aspect of the arm and the posterior aspect as well. The ulnar nerve. Now, the ulnar nerve, you can see it comes down and it goes around the medial epicondyle and then comes back up this area here, following the ulnar bone here. Now, what it's going to be doing is, if you think of the muscles that are involved that are on the medial side of the anterior aspect of the forearm, you do have your flexor carpi ulnaris, part of the flexor digitorum, and the muscles that actually make up the hypothenar eminence here. It will give you sensation on the medial half of the hand as well. Now, the other one we actually can look at, it does run the entire area, but it goes down, and like I said, under the transverse carpal ligament to give you sensation to the lateral half of the arm, and it innervates the thenar muscles here. You can also see how it's going to innervate a lot of the muscles of the flexor compartment as well. So that's a median nerve. Now, think about again why cords are called cords. For instance, why would the medial cord be the medial cord? It's on the medial side of the arm. It runs down that side. The lateral cords would run on the lateral side of the arm. And so when you look at them on models, think of where they run and how they run. Then we actually have nerves of the thorax, which are your thoracic nerves. And they are T1 through T12. And they will go to a special structure found here called the sympathetic chain ganglion. Sympathetics is your fight or flight response, And a ganglion is a collection of nerves. So you have a ganglion here, another one over here. I'll draw it in so it's easier to see. And I'll use blue this time. So you can actually see a little bulging projection here, another bulging projection over here, another bulge over here. And those are your ganglions. And the ganglions are connected by these axons here, which are going back and forth. And so if you activate one of these, you activate the entire ganglion, and that entire ganglion will activate get the heart to move faster, will cause bronchodilation, which means the bronchus, the respiratory system, will actually open up so you can breathe more, and it will actually get more blood to certain muscles. These are actually involved. These will also end up going to the adrenal gland, which are deeper in here, below this inferior, and those were going to give you that massive fight or flight response. And then you get to the lumbar plexus, and I love this picture because of its simplicity. And you can see the lumbar plexus really begins at the 12th thoracic nerve, and it goes all the way to the, well, technically it goes down to the 4th lumbar. You can't actually include the 5th. And what you have is you have a couple nerves that are important. One of the big, actually they're all important, but two of the big ones is this one coming from the pretty much L2, L3, L4, which is called your obturator nerve. You do have an here. You do also have another big one coming off here, you can see, which is called your femoral nerve. And the femoral nerve will actually give a branch called the right saphenous nerve. You do have branches to the psoas and iliacus. And you can see how all these nerves are actually named here. So ilioinguinal tells you it goes from it's going to go to the ilium and the inguinal region. But the two I tend to focus more on is the femoral nerve and the obturator nerve. Now the femoral nerve, you may remember you have a triangle here before I go. Inguinal ligament, you have a muscle here, which is called the adductor longus. And you have the sartorius, which would be running down here. And so in that triangle, you see the femoral nerve, and you can see how it branches off. And yes, it's going to innervate all the quadriceps muscles. It's going to innervate part of the iliacus, the pectineus, if you think about it, it's over here, the sartorius, and it's going to give you sensation on the lateral aspect of the thigh here. The obturator nerves, and there are plenty of them, are going to pass through the obturator foramen, which, if you remember, it's a hole in the iliaca, in the os coxae, and they're going to innervate two big muscles in particular, most of the adductors, the group, and the gracialis. It also gives you sensation of the medial posterior aspect of the thigh. And then we get to the nerve everyone likes. It comes from a plexus called the sacral plexus. And the sacral plexus is from L4 to S1 to L4. And what you have is you have a bunch of nerves coming down here. And the big one that I usually ask people to know is the sciatic nerve. The sciatic nerve will actually branch into the fibular nerve, also known as a peroneal nerve, and the tibial nerve. The fibular nerve will branch into two, so it is called the common fibular, and it pretty much is going to give you innervation in the anterior and posterior aspects near the fibula. But this whole nerve is going to actually the sciatic nerve is going to innervate the lower leg completely, back of the thigh and lower legs. Pretty much, if you think of the biceps femoris, the tensor fasciae latae, biceps femoris, the semitendinosus and semimembranosus. So that's actually those are the muscles of the thigh that these are going to actually work on, and then the lower leg. So undivided, the sciatic nerve, you can see it coming down here. And it's going to innervate mainly the muscles of the hamstrings, gives you the innervation of skin as well there too. And then you can see here you have the tibial nerve and the common fibular. The reason it's called common is because it's going to split. And the common fibular will actually move laterally. The tibial will just continue down, giving you a lot of innervation to the posterior muscles of the calf. And so the tibial nerve will innervate the plantaris, the soleus, popliteus, and give you sensation on the plantar aspect of the foot. The common fibular will actually follow the fibula and actually go anterior. So you have the anterior, the superficial, well, he'll go anterior, and you will have one that's superficial and one that's deep. So you have the deep fibular and the superficial fibular. And one of the things I did want to show you is something called dermatomes. Now, if you actually put yourself in anatomical position and think of how you develop, you can see where these dermatomes come off of. So if we were looking at where C1 and C2, you can see it be mainly the top of the head, C3 about the ear areas, and these are dermatomes. What they are is they're areas that where nerves innervate certain areas. So around the back of the ear area, you have the C3. When you start getting to the collar area, C4, C5, if you remember, you're dealing with the brachial plexus. And so you can see how it's actually going to go partially up here. C6, you'll see it comes a little bit more. C7, you can see on the palm of the hand and in the back. And it, again, has to deal with how you're developing. The legs as well. You can see where the different patterns are going to go. And they're just named for the nerves that where they go. Now, there is something called shingles that is important to know. It's a reactivation of the herpes zoster virus. And usually when someone has shingles, it will follow one of these dermatomes. And the reason that's important is what shingles does is it's a reactivation of the chickenpox vaccine, the chickenpox virus. And so when you have it, it tends to when you get it, it tends to hide inside nerves. And so when it reactivates when you get older and are under stress, it will tend to cause lesions following the nerve that it hit in. So it tends to follow a dermatome. I hope you enjoy this.